T96 mutation, it is by itself is not uniformly pathogenic for the virus, by the way. And why, for example, the pre-core mutants may participate in the progression of the disease? That's why further investigations have found that there's a possible core mutations at the various sites of the core region may augment the pathogenicity of the hepatitis C carrying the pre-core mutants. For example, these numbers like 1814, like 1874, plus the 1896 are associated with the more development of gastric cancer compared with the non-mutant strains. And certain mutations at other sites, for example, 1899, 17, 19, so they are, or they found to be resistant to interferon therapy. So, another mutations that also need the canonical 1896 pre-core mutations that may also result in much more or worse outcome for hepatitis B are what we call it the mutation at this site in the another open breeding frame for the core promoter region. And even 1762 or 1764, these may result in enhancement of the genome replication and plus the antigen negative profile and resulting in what we call the immune escape mutants. The escape mutants from the immune system will participate significantly in the persistence of the virus. That is to say, and because they are escape mutants, there is an inefficient T-cell responses. So, chronic viral infection and possibly fulminant hepatitis were shown to be associated with these tripartite mutants. Other types of mutations that may arise from the DNA polymerase, for example. So one of the most extensively studied are the mutations at the B sites that render the virus resistant to lamivudine. And by the way, lamivudine actually is the worst or have the worst resistant profile. And for example, start 15 to 25% after using this regime for maybe 1 year, may reach up to 80% resistant if you continue to use it for more than 85 years. So the most studied mutations, what we call it, the YNDD, so the alteration of motives for the conserved sites of amino acid tyrosine, methionine, aspartate, and aspartate, plus more than 11 sites, which will result in the virus highly not susceptible to lamivudine ever. The main problem of the lamivudine mutations is usually start when the therapy starts, because these mutations also have a negative effect for the virus itself. So when the therapy actually stops, then the virus will resume replication again. And this is one of the noticed from certain clinicians that they use lamivudine and the viral replication or the amount of the viral load significantly reduced. That's not the case. Just the virus become low replicative for a moment, and then the drug actually withdrawn away. So the virus will resume replication, and the persistence may ensue. The other regimes, like for example adifovir and lamivudine, for example, mutations are considered to be intermediate. For example, in case of lamivudine, there is something like 10 to 25% of resistance after 2-year therapy, and may reach up to 30% after 5 years. Something is quite similar to adifovir as well. The best profile for antiviral resistance, usually for entecavir and tenofovir. In TKVR, resistance something like 1 to 2% after even 5 years of administration. But the resistant rate may increase if the patient is already having a history of a pre-existing resistance to lamivudine. The tenofovir dysproxic fumarate resistance still now is not well actually recognized. So we have just about 4 motives for point mutation for the site of binding of tenofovir, but these mutations may increase if the patient having HIV co-infections, and it's wide recalled. Maybe the final important mutation that we have to speak about are the S antigen mutants, especially the mutation at the S1 and S2. And I have to remind you, these are the sites which are important for the viral entry, the binding of the broadly neutralizing antibodies, generated through maybe vaccination, immunity, and passive immunization. So these are true immune escape mutants. So they may affect both viral clearance from the hepatocytes and, of course, the disease progression. So the net effect of these S mutants, so failure rate of passive and active immunoprophylaxis, especially in infants with E antigen positive mothers. This is, I think, this is a famous study done in South Europe. And of course, the reinfection of the liver usually occur despite of the presence of a protective anti-versus B-S antibodies. And of course, they are misleading because the diagnosis of acute chronic persistent hepatitis B is quite reliant on the detection of the S antigen within the virology lab. And of course, the hepatitis B vaccination failed. And this is a worldwide concern that the program of vaccination may be actually significantly hindered because of the failure of these antibodies to neutralize the viral entry and to protect from hepatitis B viral infections. And recently, so we have what we call it the antiviral drug associated S antigen mutation. So, due to the overlapping nature of this genome, so there's a dual mutation in both genes may actually take place. So we will have hepatitis B variants that may harbor mutation in both enzyme and the envelope proteins. So we have a virus which usually have escape mutants and unsusceptible to antiviral therapy. Not only lamivudine, maybe further generation. And usually this is very common in hepatitis B HIV co-infection, although it's not of or contain high prevalence. A few words about the X mutation, which the data, as I said before, are still emerging. And a few studies actually in the Eastern Pacific region, Asia. So this mutation and certain deletion of this X antigen may associate with further carcinogenic role, and some of them even are associated with the E antigen negative profile mutants. A few words about how to anticipate and to screen for hepatitis B viral mutants. So by DNA analysis. So PCR methods for the estimation of the viral loads, for example, and of course of qualitative measures. But also we have to ask the virologists to screen for the possible mutations in your patients. For example, there's a classical methods maybe used more than 25 years ago, like for example restriction, fragment length, polymorphism, certain commercial assays using selective hybridization amplified fragments or using the mutation-specific primers can be tentatively identify certain mutation at different sites. These days, we don't use that. Usually we have to rely on the genome sequencing, which can be done classically by Sanger methods. But the problem here, although it's not a big problem because amplifying 3.2 kilobase of viral genome is not as hectic compared with amplifying 30,000 nucleotide genome. But still, you need more than one step in order to do that. However, these days we have the next generation sequencing methods, like for example, sequencing, like long read sequencing, so you can do the sequencing just by one step and then rely on bioinformatic tools in order to identify various type of mutations at the particular genes of hepatitis B genomes. So, in summary, the immune selective pressure, as well as the use of antiviral therapy and the viral heterogeneity capacity, actually generating something like a Frankenstein monster of a virus, which has widespread distribution worldwide. It is not confined to a one operating frame distributed to all four, and these mutations have a significant impact on the disease, so generating a virus which is stealthy, indestructible, and even the disease will progress in a more draconian way. These variants can be distinguished, can be diagnosed, can be identified using a molecular drawing technique through amplification and sequencing. And finally, the understanding the frequencies and clinical implications of these mutations may contribute significantly for improvement of diagnostic procedures, proper planning for immunization programs, and creation of most efficient therapeutic protocols. So just for the readings, you may consult these slides, and thank you very much for this actually chance, and if you guys have any question, we'll be very pleased. Thank you very much.
Thank you very much, Mosaab.
Thank you very much, Dr. Mosaab. I think he gave us, I could say, a very tough scientific sort of talk at molecular level about a very important problem here in Sudan. I think these scientific or molecular aspects of hepatitis B or any virus are very important, and as he pointed out, very relevant for even treatment and management of patient with hepatitis B. I think we have, as hematologists, we all, I think, we have to ring a bell here. I think, talking from what I see here, I have seen here in one single practice, 10 patients with hepatitis B in 1 month. If you go around and see even other why clinics in hospital like Soba or Ibn Sina or another, I think Professor Hatim or Bushra would probably expect more of this. And these are the tip of the iceberg. I think we ring a bell here. Hepatitis B might be now an epidemic in this country, and we have to realize this. I have been talking to one of the colleagues in Minister of Health, but I think probably they have got other problems than hepatitis B. But I think we have to be very cautious. We have to screen students now. On entry to colleges, I think a lot of faculties usually screen students for hepatitis B and C and HIV. Are we doing this, Professor Ala, here?
We do, yes.
Here.
We offer vaccine to all students.
Routine. Okay, that's important. I think employment, everyone newly employed should be tested as well. طبعا pregnant ladies are routinely tested usually, and dialysis, hemodialysis, and cancer patients, and also screened.
Right. I think the problem is growing, and the problem for diagnosis here is difficult as well. PCR for viral DNA load is very expensive for most of the patient around. Medications are equal. I think Entecavir is about 11,000 pounds here, and not available in at a free charge in the Minister of Health, and some people might not just cannot afford treatment for more than 2-3 months. And the treatment itself now, unfortunately for hepatitis B, is not well defined. It might be anything over 3 years or up to 3 years minimum, because if you stop that one, might be a recurrence. Just a quick question, yeah, Mosaab here. If you just could elaborate on one aspect, the relation of hepatitis D delta to hepatitis B, which is very, very problematic and serious problem, and unfortunately we don't have even tests for delta here routinely. So what is the connection between coexistence of hepatitis B and C and delta at a molecular level? And the second one, people with hepatitis B might develop hepatocellular carcinoma even without cirrhosis, as you know. So is that due to something for the pre-S1 and S2 or the CCC or whatever that will cause HCC in patients without chronic liver disease?
Thank you, Professor. Hepatitis D virus, by the way, is not an actual virus. We call it a viral. Simply, viruses are defined by saying that it's nucleic acid wrapped with proteins. Hepatitis D, it's a nucleic acid without protein wrapping. That's why just a nucleic acid that is floating, but need a protein in order to bind to the receptors, the hepatocytes, and enter. That's why we have a virus which زي ما بنقول بيتبرع بالسيركس بروتين بتاعه, as I mentioned before. So we have an empty hepatitis B subviral particle contain only the S antigen. That's why in order for hepatitis D or delta agents to pose a significant hepatocellular threat, it needs to coat itself with the hepatitis B. That's why the infection is either, it needs to get in either with hepatitis B, called co-infection, or the D nucleic acid enter the body in a patient already having chronic hepatitis B, secreting large amount of the subviral particle containing the S antigen. So the virus will, the delta nucleic acid will coat itself and then it will enter. The co-infection of hepatitis D usually results in a separate clinical profile. However, it's actually more of a benign infection. The superinfection, by the way, of hepatitis D result in something more than 9% of fulminant hepatitis. Superinfecting hepatitis D is the highest cause of fulminant hepatitis ever. Superinfecting hepatitis D is responsible for more than something like 85% of progression to liver cirrhosis and hepatocellular cancer. So, just to answer the question, D is not a complete virus, need S antigen, which can facilitate the entry of this genome to the hepatocytes. That's why it's quite or highly dependent on hepatitis B or to do that. That's why I have to enter, both of them have to enter to simultaneously or having superinfection. As I said before, hepatitis B is one of the highly heterogenic, highly variable, highly mutating DNA viruses ever. The progression to cancer, it's usually depending on these phenomena, as well as the expression of a true carcinogenic proteins, notably the X actually antigen. The Viral persistence, and in the majority of the cases, the viral replication is quite clandestine. So even it's quite masked from the immune system. That's why the oncogenic pathogenesis will continue, and even we can, or the cancer may arise without the intermediate cirrhosis or inflammatory in between, which is quite different, for example, from hepatitis C. What we understand right now with hepatitis C, that the continued inflammation, the continued cirrhosis, and over expression of the inflammatory marker, this is the main reason for the cancer in case of hepatitis C. But hepatitis B, due to the high heterogeneity, insertion of the carcinogenic proteins, and the virus is quite stealthy, this is the main reason why the cancer may arise without an intermediate inflammatory step.
السلام عليكم. أول حاجة we thank Dr. Mosaab يعني for such an interesting talk. طبعا people will probably have found this lecture difficult. طيب الموليكولر biology دي يعني is the base for mutations, the base for hepatitis B. فيروس ادفانسمنت انه الادفانسمنت اللي حصل في الهيباتيتس بي فيروس recently الديسكفري اوف ذا ميوتيشنز اند الجينوتايبس اند دراج ريزيستنس دي هي البيز للادفانسمنت اللي حصل in the past few years في الهيباتيتس بي فيروس ده كل الموليكولر ويرك ده اوكي يعني we've noticed انه هسه when people started treating hepatitis B virus they started using lamivudine, which by the way is a very very effective drug, the most effective drug. لكن gradually people realize that as you go on after 2, 3, 4 years the drug doesn't work because people have developed a mutant gene. Okay, so now people, as Mosaab mentioned, they are using drugs like entecavir and drugs like tenofovir. And he also mentioned that if you have already resistance to lamivudine, then you will probably have more resistance if you start entecavir, because they are more or less, entecavir and lamivudine are both nucleoside analogs. They are from the same group. So as clinicians, we are advised by our molecular genetic specialists like Dr. Mosaab, if you have a patient who has developed resistance to lamivudine, don't start him on entecavir. Start him on tenofovir, which is a nucleotide analog. It's a different class. Okay, so all this work, okay, although it seems difficult, it sounds difficult, again, as we advance in the genetics and in molecular biology studies, I think as medical students and as young physicians, people will be able to understand more what's going on. Okay, he also mentioned, I think if you were careful in listening to the lecture and some slides, it has all this work has an impact on vaccination. So in Sudan now we have a very strong vaccination scheme, okay, for hepatitis B virus in children, okay, and I think the coverage according to the WHO is 85 to 90%. Like now he's mentioning that occasionally these vaccines may not work if you have certain mutations, okay. Certain mutations also will make you more liable to develop hepatocellular carcinoma. Okay, that is why even if although there are certain guidelines for treating people with hepatitis B virus, okay, with chronic hepatitis, there is an advice that patients with a family history of hepatocellular cancer, it's best to treat even if there are no clear indications for treatment. There are clear indications for treatment. in hepatitis B virus. Okay, if you have a high ALT, if you have a high viral load, okay, if you have F2, 3, 4 on FibroScan, there are certain indications. But patients who are hepatitis B virus positive with a family history of hepatocellular cancer, they may have certain mutations which make them liable to develop cancer. So the advice is to treat them even if there is no clear indication for treatment. Okay? So this has helped a lot in modifying, okay, in advancing المانجمنت of hepatitis B virus. Okay. By the way, hepatitis D طبعا in this country has been studied, very few studies, maybe 3 or 4 studies, لكن it may reach up to 20% in patients who are hepatitis B virus positive. We find many patients who were well controlled, suddenly they decompensate, okay, or the drug doesn't, you find that your drug is not working anymore. So some of these may have super infection, as Mosaab mentioned, لكن unfortunately we do not test for this. Okay. طبعا Professor Aladdin mentioned something about offering vaccination to all medical students, and I make a habit of asking my students when they come, 6-year medical students, okay, how many of them are vaccinated, and it is quite disappointing, by the way. Less than 50%, maybe 30, 40% are vaccinated. And some of those who are vaccinated, they've only had 1 shot or 2, they haven't received the full. You have to realize that hepatitis B virus is a major problem in this country. Okay, major problem. And that as doctors, when you go to the hospital, you are definitely exposed. Okay, so the only protection the best protection you can get is getting fully vaccinated before you graduate from this college. Thanks, Mosaab. Interesting talk.
حاتم معلش
اتفضل.
كلامك كويس وتمام.
ممتاز.
وريني لو زول عنده هيباتايتس بي سسبكت تعمل ليش؟
Suspect يعني.
يعني قلت شكله ده عنده هيباتايتس بي انا معك.
لا شكله دي.
اوكي ثاني حاجه مثلا core antigen what does it mean؟ لو مثلا this patient with the core antigen positive, this surface antigen positive, this is
ايوه practical يعني.
practical.
والله طبعا it is difficult to suspect انه فلان عنده HBV surface antigen, لكن most of the patients, by the way, who present to the gastroenterology or the hepatology clinic, they are asymptomatic. Most of them are people who are trying to travel abroad. Okay, ناس عايزين يسافروا, they go to one of these embassies, okay, and they get tested and they're positive and they're asymptomatic, and they've had the infection some time ago, maybe in their childhood, maybe as teenagers or adults. Okay, so if you have somebody who's antigen positive, they usually have this rapid test. Okay, you have to confirm that by ELISA. You make sure they are positive. لكن يعني ICT is a very sensitive test, very sensitive. So in more than 90% of the cases, if you are positive on the rapid test, you are positive on your ELISA. Okay, so if you are positive, then you definitely have hepatitis B virus infection. Okay, you need to confirm that this is not an acute infection. You can confirm that clinically, and if you have an acute infection, you are usually symptomatic. You don't have to be, like you are usually symptomatic, but most people are asymptomatic. Okay, so but to confirm this, you need to do a core IgG, okay, to make sure that this is a chronic infection and not an acute infection. And acute infection will resolve in 90% of cases. Okay, once you know this is a chronic infection, you have to do your liver functions, of course, to make sure that the liver is not involved, there is no liver cell destruction. You have to do the E antigen, and by the way, more than 80% of the population here who are hepatitis B surface antigen positive are E antigen negative, which is not necessarily a good thing. Okay, they do have low replication, okay, but they are still infectious, okay, and they can still get chronic liver disease and liver cirrhosis, and they can still get hepatocellular carcinoma. Okay, so you do your antigen, you do your hepatitis B virus DNA viral load, you do your abdominal ultrasonography, and you do your LFTs, and then you can decide on which way to go on treatment. Okay.
It's not working. It's not
I'm asking about revaccination. Sorry. My name is Sumaya. Assalamu alaikum. My name is Sumaya. I'm community medicine registrar. I'm asking about revaccination. If a person already took 3 doses, when we have to revaccinate him. Yeah, yes.
Okay.
Thank you.
Anyone actually who is vaccinated, the majority of people born maybe before 2005 or 7 in Sudan, maybe they are not quite vaccinated. Maybe people vaccinated outside Sudan, they are advised to have a booster dose. So you have 2 options if you have 3 doses, either to get your booster dose or to come to somebody like me to do what we call it anti-S titer. If they are quite optimal, usually no need for booster. If take a booster, that's all. Okay. If actually you are vaccinated more than 10 years. يمكن بس إضافة بسيطة دكتورة يعني سارة. The main question that you need to ask if the patient suspected hepatitis B, first one, if this patient having hepatitis B or not. What is the stage of this patient? And what is the possible outcome for this patient? In hepatitis B is quite difficult, but we use what we call it a markers, okay? And it usually looks like this. So in order to establish in a tentative way that this patient having hepatitis B or not, so we have to rely on the S antigen. It can be done by various methods, but the most reliable, specific, sensitive is to do it maybe by ELISA or by immunofluorescence in the virology lab. And then, this is question number 1. S antigen positive, having hepatitis B. If antigen negative, don't have it. The other question, what is the actual stage for this patient? If this patient is acute, if this patient is chronic, is the chronic immunotolerant, if it's chronic immunoactive, it's a low replicative, it is latent, or it's just a carrier. That's why you have to rely on other features, including something called anti-hepatitis B core antibodies. In case of IgM, it's acute. IgG, this is a persistent infection. And then what is the prognosis for this patient? Is this patient going north or going south? North means you may recover. South means that it will go to the long-term sequelae and the cancer. That's why you have to rely on the E antigen. That 15 years ago. And these days, because the E antigen become not a reliable surrogate marker for the patient prognosis, that we need to rely on the DNA. So we have to amplify the viral genome, for example, by PCR. So we have many methods today. I think you'll hear about real-time PCR. They can do 2 things. Tell you qualitatively, patient having or not, and how much virus in this patient plasma. High viral load, indicating that the patient is going south for the long-term sequelae. Maybe if this device is low replicative, then you have to make further interpretation. So that's how actually to approach the patient, because the determination of the actual state of the hepatitis B viral infection is quite dependent on these markers: viral proteins, antibodies, and the viral DNA.
معينه كده. السلام عليكم ورحمه الله. الموضوع سعيده جدا ويعني فيري اكسايتنج توك، وفعلا وريت الهيباتيتس بي از فعلا فيري كومبلكس فيروس. انا جست فيو بوينتس يتطرق لها كان بروف حاتم، بس عايز اكد للجونيور للستودنتس والجونيور فيزيشنز انه this is truly a public health problem. يعني البريفالنس في السودان most of the studies are actually made by our own professor حاتم مضوي. The prevalence في السودان بتاعت الهيباتيتس بي is around 12%. يعني out of 100 persons في 12 patients who are hepatitis B surface antigen positive. And we are seeing an avalanche of patients في الكلينكس. مش لانه في awareness، يعني غير الناس الدايرين يسافروا، في الطلبه، في النسوان الحوامل، وبقى في مخدمين كتار جدا بيكشفوا على المرضى ولاسباب الحقيقه برضه غلط. يعني انا هوريها لكم بعد شويه. يعني المخدمين حتى في شركات هنا بيطلبوا من الموظفين انه يعملوا كشف اول ما يكون بوزيتيف، اول قرار تو تيرمينيت ذم فروم ورك. رغم انه الموظف مثلا بيكون حداد او سباك، يعني ما جراح ولا حلاق ولا طباخ ولا زول who poses risk. ف it's a huge problem which means it needs to be managed at the primary care level. اللكشر بتاع مصعب، يعني انا زول شغال هيباتولوجي لي سنوات طويله، بالنسبه لي انا ذاتي معقد. فاي تيك الكلينيكال بوينتس في احتمال ليكشر زي ده يقوم يخوف ناس البرايمري كير انه اول ما يجيك عيان بتاع هيباتيتس بي سيرفيس انتيجين بوزيتيف ريفيرهم لبروف حاتم ولا بروف الباغر. او and if this is all they do they will not cover. فمعناتها at the primary care level it should be managed such as diabetes وhypertension. اي زول في البرايمري كير ليفل should know what needs to be done. والحكايه لو لخصناها الجايد لاينز موجوده. يعني جاك زول ريفير هيباتيتس بي قال لك يا دكتور انا نصيح بس عندي هيباتيتس بي سيرفيس انتيجين بوزيتيف. في 3 حاجات المفروض تعملها. واحد، the first question is this patient a carrier or is this patient who has liver disease. ده السؤال لازم تساله. The vast majority if you looked at the natural history of hepatitis B من كل 100 عيان hepatitis B surface antigen positive يمكن 4 or 5% بس will end up having some form of liver disease, liver cirrhosis. ال 95% لو ما مشوا كشفوا حيموتوا من الضلة الواحدة من غير ما يعرفوا عندهم hepatitis B. فمعناتها your job is to determine does this patient has liver disease ولا لا. بتعرف كيف؟ physical examination. في اسايتس، في سبلينوميجالي، في جوندس، في سبايدر نيفا، في اي استكبار كرونيك ليفر ديزيز ولا لا؟ ما في. الخطوه الجايه انفستيجيشنز بيزك LFT التراساوند. ما في سيروتيك ليفر، ما في ثرومبوسايتوبينيا، ما في ابنورمال ليفر انزيمز، ازول ده كارير. الخطوه الثالثه get a PCR. لو اقل من 2000 تعال كل سنه عشان نكشف لك، معناتها انت جهاز المناعه بتاعك بيثبت المرض. اعلى من 2000 they need to be on antiviral treatment. الانتيفيرال تريتمنت الافكتيف في السودان هو الانتيفير، وحصلت مجهودات كبيره جدا من الجمعيه السودانيه حق الجهاز الهضمي. بقى في شركه سودانيه بتصنع بقى لوكال متوفر. في البرايفت حق الشهر ب 11000 زي ما قال البروف، في الامدادات ب 5000. فديس از وات نيدز تو بي دان. طبعا السودان بلد العجائب، يعني انت حتى البراكتس ما بتقدر تعمل. يعني الاي انتيجين الحياه دي غاليه، يعني البي سي ار بالالاف عشان تمجد، وده كروشال. الاي انتيجين بقى مهم. انا ما اعترف لك قدام الملا يا بروفيسور ما بطلب الاي انتيجين. ليه هو مهم؟ لكن الاي انتيجين زي ما هو قال في السودان البوبيوليشن بتاعنا معظمه اي انتيجين نيجاتيف. و it is not a predictor of infectivity. Its use is to determine how long you treat the patient. لو العيان E antigen positive, you can stop the treatment when the E antigen seroconverts. ولو negative, التريتمنت المفروض تكون indefinite. It's going to cost the patient more money. المهم يعني البوينت اللي بدي اعملها انه primary care physicians you have to have the tools to deal with this and only refer complex cases. دي النقطة الأولى. النقطة الثانية ترى أكرر عليها الميديكال ستودنتس والفاكسينيشن. If in doubt حتى لو ما in doubt get ده تيست متوفر ذكره دكتور مصعب الانتي هيباتيتس بي سيرفيس انتي بودي تايتر لو اكثر من 10 international units you are protected لو اقل get a booster الحاجه الاهم don't get vaccinated without being tested first you have to be tested first وما بس only for your sake لكن for the sake of your patients لانه if you get vaccinated وانت infected you will pose risk to other patients. طيب سؤال ثاني بيراود الميديكال ستودنتس if I'm hepatitis B surface antigen positive لو عندي hepatitis B does that hinder my profession؟ في السودان حاليا ما في اي قوانين بتمنع زول يدخل الكليه او يتخرج من الكليه او يمارس المهنه لو hepatitis B surface antigen positive. وحتى في دول الثانيه في UK و USA they don't stop you لانه لو في قرار انه to stop you from practicing medicine اللي هيحصل شنو؟ doctors will not be forthcoming انه to tell فانت once you have a low DNA you pose minimal risk to your patients even if you are an obstetrician or a surgeon. لكن بنقول للناس عشان ethically it might change your decision of the choice of specialty that you are going to do. المهم الناس ما تتهيب الهيباتيتس بي it sounds complex لكن المفروض تملك نفسك تجتهد المعلومه انه at the primary care level what to do. انا بدي استغل الحكايه دي اسال دكتور مصعب في السودان هنا نحن كهيباتولوجيست when to refer a patient يعني مرات الانتكافير هسه شغال معانا كويس والحمد لله الى الان انه لكن بيجوني patients خصوصا I don't know patients from ما اعرف التجربه دي patients from South Sudan they come in with millions of viral DNA copies ممكن يكون في genetic predisposition and with entecavir بيحصل suppression لكن it does not go below الثريشولد اللي انت دايره بتاع 2000 فبصوره عامه امكانياتك هنا شنو في السودان نحن نحول لك عيان لشنو؟ for what studies؟ هل في اي حاجه من الميوتنتس دي clinically evident لو زول بديناه على انتي فايرال والفيرال لود ما نزل؟ what is the utilization of the studies that you can do to help us؟
بس سؤال يا دكتور ما فهمت يعني تقول يمكن كده شغال كويس ما يفهم
شغال كويس طيب قال لي بروف يا بروف حالي طيب نقول القصه دي ولا ما بدها نقول لا احكي لكم القصه دي في سوبر طبعا يعني getting the status of professor في الكليه دي ما حاجه سهله مجهود صعب جدا جدا فانا وبروف حاتم في صوبه في نفس الوحده فلقى انه الطلبه والريجستراس شاكيني يا بروف قام قال انت شو القصه دي؟ انه يقولوا لي يا بروف قال لي انت بروف بتاع خلا ساكن فهسه لو تقول لي يا بروف انا اسمي بروف خلا وش طيب شغال كويس بمعنى it suppresses the viral load. This is what I mean. It suppresses the viral load.
So for example يعني genetic code has sustained the aerobic response. So
in case of blood-borne viruses, so usually we define the tracking effectiveness or efficacy by doing the following. Firstly, in any case of hepatitis B, C, HIV, viral load need to be done in a regular basis. Worldwide, it's done monthly. Maybe here due to certain reasons, maybe it's done maybe less than that. The machine that do the PCR, it need to have something called a very low limit of detection. And the results, it need to be something that we did not detect the virus in our assay. Okay? Not 100, not 150. It need to be undetected at all, depending on the machine. And we'll come to that later. So, undetected viral load, something like 3 months after initiation of therapy. after the end of treatment, and even 6 months after the stop of the treatment. So here we can say this drug is active. This is what we call it sustained virotic response, right? The problem that we have here in this country,
Isn't SVR, isn't that term reserved for hepatitis C?
yes, yes, but also can be applied also for other viruses, like any blood-borne viruses. As you say, because we have to make sure that this virus has eradicated. Okay, that's why when you stop the treatment, so the viral load should remain undetected, even further after the cessation of the treatment. So now we can say that this drug is active or شغالة. Okay. If we can do that, that's fine. So if in Tikavir, which I don't know how that's happened, if this is getting in Tikavir, so that's fine. However, I think in Tikavir is not the first choice, in just my opinion. First choice is tenofovir, this proxyfeverin. Even now, it's replacing old regime even in HIV. That's why, because it has a very low limit of mutations, till now the report of the resistance of class B worldwide is extremely low.
So cost or availability.
Yes, understand.
عايزين مناضل بس يدينا view about stamina.
في طبعا زي ما قال دكتور مصعب الانتكافير از ذا بيست سوري التنيبوفير از ذا بيست كويس اول حاجه لو فيري لو الريزيستنس افتكر ما unknown يعني او less than 0.1% ولا كده التنيبوفير از ذا بيست لكن سايد افكتس طبعا في مشاكل رينال فيلر ما بتقدر تستعمل عنده مشاكل بيعمل بون في اوستيو كوروزيس في بون بروبلمز وفي حاجات زي اوكي لكن والافيلابيلتي طبعا التنيوفير في السودان ما موجود الانتكب احنا بنستعمل الانتكب وانا ما اقدر اقول يعني شغال معنا كويس انا ما اعرف ما بتخلى يستعملوا ده مساعدين لكن طبعا يا بشرى المليون في غالبا لانهم دي انتيجين فوسفور في الاغلب لانه الانتيجين نقدر بيكون ثالث اوكي فما اعرف دي برضه واحده من علامات الخير يعني اوكي طيب معلش في one of our medical students محمد المعتصم لان احنا كنا تكلمنا عن الفاكسينيشن medical students وكده وهو كان في سنه خامسه الشغل بتاعه الديزرتيشن حقته او الريسيرش بتاعه كان على الهيباتايتس بي فيروس فاكسينيشن فما اعرف محمد تجي تدينا بس فكره بسيطه مع محمد المعتصم ايوه تعال حاجه بين انترستنج يمكن لنا احنا كلنا عشان نتعلم حاجه محمد 6 year medical student كان كنت معانا قبل اسبوعين كده كان معانا تفضل.
السلام عليكم ورحمة الله. I'm Muhammad Al-Mu'tasim Salah, 6-year medical student here. My research in 5th year was about hepatitis B, knowledge, attitude, and practice. Within the questions of the practice, كان في 2 questions concerning السؤال اللي اتسأله بشوية. The traditional medical students هنا are vaccinated. السؤال الأول كان have you ever received hepatitis B vaccine؟ يعني 1 dose 2 doses أو 3 doses كلهم. Among the medical students البرسنت بتاعت الناس اللي قالوا yes كان 58.3%. 58 يعني أقل من التلتين. ده among the medical students اللي أخذوا على الأقل 1 or 2. يعني about 40 ما أخذوا نهائي. طيب السؤال الثاني كان have you completed hepatitis B vaccine schedule? The people who or the respondents اللي said yes كان 36.4. 36.4 are the only students اللي كان have the 3 doses of hepatitis B vaccine. الحاجة دي among batches from batch 92 لحد 98. الحاجة دي يعني هي بتختلف أسبابها وكده. في برضه ريبورت عن الأسباب في الريسيرش بتاعي إذا حابين.
ورينا أهم سبب شنو؟
أهم واحد that I don't know where to go and receive it.
ده سؤال للعميد.
نجاوب احنا.
لازم تجاوب، ده سؤال مهم.
طبعا محمد المعتصم ده انا كان عملت له الانترفيو وهو داخل سنه اولى، تذكر يا محمد؟ فكبر ما شاء الله وبقى يعرف الهيباتايتس اكثر مننا.
It is والله with such pride يعني شوف our student for doing all these useful researches and good research يا اخوانا is research that answers questions, a research that fills gaps in knowledge. This is the importance of research. There is no point whatsoever in doing research that has been done. You should not reinvent the wheel when you're researching. This is just waste of time and resources. But this is excellent research. الفاكسينيشن والله بتمثلوا الرابطه والجمعيه الهضمي ده very helpful. انا هسه جوني اولاد الرابطه اسبوع بخصوص الفاكسينيشن، وكان في financial problem وضربت للدكتور عبد المنعم اللي هو هسه رئيس الجمعيه بتاعت الجاسترونترولوجي. Fortunately enough, he just solved this problem, the financial problem, والله over the phone when I conveyed المسج لأولاد الرابطة، وحتى قال لي اديهم تليفوني عشان يتواصلوا معي. فافتكر الرابطة هي المفروض عليها انها to disseminate الفاكسين. الفاكسين is available for everybody and it's free of charge. فبفتكر انه مسألة تفتكر بس اللي بتحلها الاعلام ولا شنو؟ نحلها كيف في البروجكت بتاعك؟
الفكرة إنه people do know.
لكن نحلها كيف؟
الإعلام وسائل الرابطة اللي بتساعد في الحل.
طيب نحلها بالاعلام
هو
ووسائل
يكون
الرابطة.
الامتحان بعدين.
تديهم
إذا ما جاوبوا.
انك if you
شهادة
are negative,
تضعيف.
take vaccine and go راح سنة بدون الأمان.
الأماكن ما بيجوا الفاكسينيتر يصيروا في الكلية والرابطة بتعلن ثرو الوسائط بتاعته.
خلاص هم
and they vaccinate the students.
بعدين التنسيق مع
هل في الريسيرش بتاعك في أي concerns about side effects from the vaccine؟ يا إخوان مثلا زي الكورونا فيروس vaccination. The low uptake of the coronavirus vaccination is because of concerns of side effects. The media is full of إنه إذا كان أخذت كورونا فيروس vaccine هتتكلم صيني ثاني. مش تقول لنا كده ده؟ These are concerns. هل في concerns about المعتصم؟ هل في concerns about side effects from the vaccine?
ما كان في concerns about the side effects. ما سألت أصلا منه.
Isn't this is very easy to solve. في
other
ممكن تقول لنا other causes؟ نشوف نحلها كيف.
اوكي ده كان الموست كومبوز. طبعا الريسيرش ده انا عملته في نهايه 2021 بدايه 2022. في السنه اللي فاتت دي الرابطه كان عندها نشاط انه جابوا فاكسين في مكتب الدواء. كان يعني نشروا الاعلام للدفع وكده، وفي ناس يعني الدفع الصغيره مشوا اخذوا فاكسين. بس الريسيرش ده كان قبل النشاط ده يعني. الاذر كوزز في research that I don't see the need. ما كان يعني عارفين اصلا، يعني ناس اولى وثانيه ما عارفين هيباتيتس اصلا شنو وفائده الفاكسين. Others say that I don't have time. طبعا دي about 5% بس منهم يعني. الباقي برضه كله اقل من دي. I am afraid of contracting the virus from the vaccine.
هذه concerns about safety. بالضبط زي الكورونا فيروس.
ده كم البرسنتج؟
دي about 4%.
كويس.
طبعا الفاكسين ده it's not a virus يعني. It's the surface antigen. You will never ever contract the HBV virus from the vaccine. And it's not even a virus. Okay, it's just a protein.
أقل نسبة قبل النشاط قبل ما يتوفر في الكلية هنا كانوا شايفين that it is expensive about 2 to 3%.
شكرا جزيلا. This is very useful. الحاجة والله وخلنا برضه بالنسبة للستودنتس في الجونيور doctors and I said this juncture. This is extremely good research. And the next step in doing good research is to disseminate it. Now the only way to disseminate research is to publish it. Now we have الحكيم and I told the Rabta الفاتح and I tell الرابطة الحالية إنه نعمل عدد من الحكيم خاص وأنا قلت إنه أنا I managed to find some funding for it. إنه العشرة thesis الأوائل بتاعت سنة 5 to be published في هذا العدد. The students still are not very forthcoming with this. Like I'm still prepared, and I stand by my word. I'll be able to fund. إذا كان جبت لي العشرة الأوائل في البروجكتس هسه أفتكر امتحنوهن 2 weeks ago. فيشوفوا بس العشرة الأوائل دول we can publish them ننزل لهم عدد خاص من الحكيم لأنه this is the only way to disseminate them. لكن حسي this is excellent research, excellent results. جدا by all means. Which absolutely. And this is what research is about. And problems that face research worldwide is to how to translate research from bench between two inverted commas حتى لو كان epidemiological research into clinical practice. So if we know the barriers to low vaccination uptake, and we know them now from this project, we can address them and improve uptake and protect the students. We protect the students from hepatocellular carcinoma. There isn't anything better than this. There are so many preventative measures in cancer. One of them is smoking cessation that concerns me, and the other one is HBV vaccine, and the other one is cervical cancer vaccination. I think cancer is not a preventable disease to a large degree. But this is really excellent.
بروفيسور علاء انا يمكن الموضوع بتاع الفاكسينيشن يقول ديبارتمنت اوف كوميونتي ميديسين برايمري هيلث كير اند كوميونتي ميديسين to be coordinated مع الجهات الثانيه وزاره الصحه وكل الناس الثانيه. افتكر مصعب thank you very much. Your talk was excellent and تعبت عليه.
My PhD proposal is about hepatitis B infection and the relation with hepatitis B infection. I'm going to do my proposal molecular biology studies. I'm very happy to be there and I'm lucky and I want to أعرف contact you لأنه أنا عايزة أشتغل شغل بتاع NGS as you said the next generation sequencing and genotyping, viral load and as you know the facilities is very low in Sudan. بحاول أن to contact another institutions abroad to do my experiments. فما أعرف تقدر تساعدني أنا أوصل درجاتي في collection of samples. أنا بعمل collection every single ما كنت بلقى sample positive بلقى عندهم الفيروس load. I'm very happy. Thank you. Is there a relationship between hepatitis B mutants and coronavirus?
ارفع صوتك يا دكتور سؤال.
Is there any relationship between hepatitis B mutants and coronavirus?
Coronavirus?
Yes.
طلب صغير منك
إجابة على السؤال.
جاوب وبعدين بس دارين ندي مصعب ولدنا ده 1 minute as well. مصطفى.
بس معلش طبعا لانه الجهاز تاعي قطع كهرباء لكن انا I put my
contact details, my website, my email. I will try to make sure that this presentation is distributed maybe within the different platforms. So I think we'll get that. We'll see that later. No problem. Actually, usually COVID-19 progression and complications is quite related to where actually COVID-19 causes disease. Liver is the least sites that COVID-19 may affect. So it may affect the heart, may affect, extrapulmonary sites, may affect the blood vessels, may affect the kidneys, even may have some receptors in the central nervous system. The liver really is the least site to do that. So I can find any plausible relationship between the mutants and the, I think you mean the complication for the COVID-19 infection. Yes, even I can tell how.
بس قول لنا حاجة بسيطة.
السلام عليكم، أنا مصطفى مهلول، سنة خامسة كلية طب جامعة الخرطوم. كان الثيسيس بتاعت سنة خامسة عملتها regarding knowledge attitude and practice midwives in Mosaab teaching hospital, سعد أبو العلا teaching hospital about HBV hepatitis B. فكانت reasons نوع مثلا موضوع النولج البرسنت بتاعت البارتيسيبنتس who have average knowledge كانت 50%. نصهم بس هم يعني based on a questionnaire اللي هو which is almost standardized كان من research القديمة أو قبلين يعني 50% منهم كانوا عندهم average knowledge and 50% who doesn't have average knowledge. Attitude 80% has a favorable attitude regarding practice. It was divided based on إنه جزء منهم have a needle stick injury history. الهيستوري بتاع needle stick injury كان almost 56% منهم عندهم history بتاع needle stick injury within البراكتس حقتهم. فاللي عندهم needle stick اللي حصل لهم needle stick injury around 25% منهم have poor practice. الماع حصل لهم needle stick injury قبل كده around 1% منهم have poor practice regarding hepatitis B. Regarding the vaccination status, almost around 20% منهم ما fully vaccinated. Midwives شغالين. To reflect just إنه والله يا أخي ليه كان about الميدوايفز لأنه I think إنه هم pivot point في إنهم at a single يعني visit هم ما بيقابلوا عيان واحد هم بيقابلوا مش عيان هم بيقابلوا شخصين يعني هم الأم والبيبي في سيريا فما يعني والشافع definitely unvaccinated فهنا الريسك بتاع انهم to transmit او انهم to facilitate الحاجه دي كبير لبيشنت و unvaccinated patient يعني within a area. فدي كانت الحاجه المخصوص اتعملت عشان الانسان. موضوع بتاع statistics انه كان في relations اللي اتعملت ما لقيت لي significant relation statistically كده بين النولج والاتيتود والبراكتس مع باقي التفاصيل بتاعتهم يعني سواء كانت الفاكسينيشن ستاتس او كده. لكن mainly موضوع الريكومنديشن ممكن يكون اهم واحد هو موضوع الفاكسينيشن انه to complete الفاكسينيشن بتاعهم يعني under the supervision of the vaccination unit او quality control unit في المستشفى. وجزء منهم اصلا كان يعني باعتباره اشتغل في كم مستشفى لكن ستيل ما فولي فاكسينيتد ما عارف كيف.
education awareness يعني صح؟
شكرا.
شكرا يا مصطفى.
شكرا يا مصطفى. Very good. I think the beauty of this presentation is that it generated a lot of discussion or feedback even from our students. This is what we can say our goal of disseminating knowledge, exchanging knowledge as well. زي ما قلت مثال على المفروض الحاجات تتنشر. هو المشكلة if you publish it. المشكلة في مش already published who will read it. دي المشكلة. الناس they don't read journals. يعني very few people read it now electronically. أنا أخليه هي الندوات free discussion والأشياء دي هي أهم to disseminate knowledge as well as others. طيب قبل ما نختم نسأل الفلور هي مصعب عنه. How is hepatitis B transmitted? Say, what is the most important mode of transmission of hepatitis B in Sudan? لو سألناكم بدون ما نديكم خيارات. كده واحد. Yes? Do you have evidence published or that is impression? From Sudan? لا احنا talk about Sudan. يعني ما هو بيفتك له هوريزونتال، ما هوريزونتال ده ما كثير يعني. طيب هنا هوريزونتال ذات خلي vertical transmission from mother. Yes. دي طبعا اليد الناس mother probably are not tested and not vaccinated. معظمهم بالذات more than 15 years or 20 years back. في other mode of transmission نديكم خيارات. طبعا blood transfusion should not be لانه all blood is now screened. فدي ما حتى في الام سي كيو بنحط عليهم about 2% قالوا يس. طيب IV drug abuse ما كثير طبعا عندنا fortunately لغايه الان ما في IV drug abuse. طبعا دي معظمها طبعا worldwide is hepatitis C because they are vaccinated against B. طيب دي ما اظنه very high IV ما عندنا الحمد لله. طيب في حاجات ثانيه يا جماعه انا بسال بعض المرضى بساله غير فيرتيكال في اشياء ثانيه يعني شيرنج نيدلز ثاني في حاجات ثانيه يعني دنتال كير يا جماعه. دنتال كير الناس هيباتيتس بي they don't tell the dentist ذات انه عنده هيباتيتس B or C or whatever so that they can use what is called one pack system. طبعا one pack system is very expensive here لكن it is very safe. one pack means disposable. لما لك اي حاجه ويرميها. لكن sterilization again you have to tell the dentist so that they take extra measures عشان to get very safe. بعدين الحلاقه انا سالت واحد very clever very simple وعرفت منه الحلاقه العشوائيه يا جماعه. انتوا شايفين انتوا عارفين الحلاقه معظمها عشوائي. مشيتوا الاسواق المحليه هسه انا اقول لكم امشوا وراء كمبوني هنا الالعاب بتاع الكمبوني هنا هنا وراها احنا بنحوم البلد دي مما كل ستودنتس هنا كمبوني دي كنا بنلعب فيها الكوره. التمارين بتاعتنا كلها هناك. الحيطه بتاعتنا الشماليه امشوا بهناك. الناس الماسكين المرايه بيحبوا لك بيجوا ناس المحليه يسكون يقول لك قابلنا بالشارع الثاني لانه يرهب هاف دن right. They use shared كل اللومات دي كلها shared. فالحاجات العشوائيه بعدين في حاجه الحجامه ودي حاجات انا سالت منها يا جماعه. الحجامه ما كثيره لكن طبعا الحجامه نوعين. في حجامه فيها ناس بتفصل يقول لك الدم اللي هنا يطلع يعني هي الحجامه not treat everything زي ما كاتبين بعض اللي هنا هذا التنشن دايبيتس روماتويد ارثرايتس هيباتيتس سي. فالناس اللي بيعملوها عشوائيا دي برضه زي الشيء النيدلز. فدي البراكتسز في الكوميونتي. طبعا الحاجه الثانيه النوت ديسكلوز اللي هي سكشوال لأن people are shy and don't ask about that also. لأنه دي حاجه hidden.
بس مداخله بسيطه انه التريتمنت اوف جوندس في البلد دي هي الكي والبسيط. واللي بيحصل انه في الحي بيكون المتخصص في الكي زول واحد فانت بتجيب له عيان جوندس يعني موست لايكلي عنده فيري هاي فايرال بيقوم بيكوره وبيقوم بيجي بكره ما في زول جوندس بيجي زول عنده وجع ظهر ما هو لازم يطلع فلوسه بيقوم بيفصله برضه بالموس حق الزول اللي كان جوندس
هذه ممارسات الاجتماع والناس خمسه هي لو في واحدين كل واحد يعمل لنا ريسيرش في الاريا دي الممارسات الاجتماعيه دي نقول لها. طيب زين very thank you very much Dr. Mosaab. I think it was a very useful and thank you very much. Next Thursday we'll have a special session about cancer therapy from a distinguished speaker from USA, Dr. Bushra. Recommended him. Shami Sheikh. Inshallah next week we will disseminate the announcement. شكرا جزيلا.